Thanks, everyone. Hi, it looks like there are about 140 of you on the call, so thank you all. I mean, it's nice out in here in Cleveland. It's like 70 degrees and it's beautiful outside. And there's probably a part of you that wants to be outside or wants to be watching Netflix or wants to be doing something else. And the fact that you're giving me your attention and trying to learn something is something I take really seriously. I want to make sure that this hour that we have together is worthwhile for all of you. And so I want to start with this set of bite wings. And I don't think this is a unique set of bite wings. This is probably, if you go to work tomorrow, you will see bite wings that look like this. And depending on who you are, depending on your philosophy towards practice, depending a little bit on your background, how you were trained, etc. All of you looking at this set of bite wings are starting to list in your mind what your recommendations for a patient would be. Okay. And that's kind of weird because I would say with great confidence that of the 140 people that are on this call right now, there is probably a good chance that there's 60 different recommendations that might be made. I know this because I practice with my wife, and her and I are identical. We're identical in terms of dentistry. Her and I, we both graduated from the University of Michigan in 2004. We both did a 1 year residency in downtown Cleveland from '04 to '05, and we both started our practice. When our practice wasn't making enough money, we went and worked for Aspen Dental. And then when the practice was busy enough, came back to our practice. I mean, we are so close to identical in terms of our dental experience. You would think that the two of us looking at this one single bite wing would have equal recommendations, equal diagnosis. And the fact is, I remember doing this little experiment several years ago. And at that time, she said, she looked at that and she said, I'd probably recommend four fillings. And I was like, four fillings? Well, what about five? What about 5DO? And she was like, well, what about it? I'm like, well, I don't know. The old filling was kind of crappy. She's like, it doesn't look that bad. And then I'm like, what about 28? And she's like, dude, 28. 28's not through the enamel, fool. And then I'm like, dude, you're not through in the enamel. And then the two of us will fight and it would be all uncomfortable. And we would get home and the kids would be like, mom and dad are fighting. And this is like the two of us couldn't be any more similar in terms of our dental experience. Yet the two of us had very differing opinions about what should happen with this patient. And while some of you think that that's okay, I'm not sure that's okay. I think that it's 2026. We should be a little bit more objective in the way that we look at things, and we should embrace tech a little bit more. And more than anything, I wouldn't be doing four fillings, three fillings. I wouldn't be doing a million fillings when I saw something like this. Okay. Before I go on, I want to make sure you all know that you can download my lecture for free. Just go on Catapult Education. You can use that QR code. This entire presentation. Actually, I have a full day presentation that is all downloadable for free. You can just access that using the QR code. And then if you were to go on my website, which is bebetterseminars.com, I have a tab on my website called Handouts. And if you'd like, you can actually click on my handouts and you can print anything you want. If you want to print out my handout about implant overdentures, if you want to click on my handout about ergonomics and back pain, it doesn't matter. I don't even collect email addresses or anything like that. I just want to make my handouts free and available to the public. And hopefully they might help you at some point. And so just keep that in mind. My website is bebetterseminars.com. You can see that right there. Okay. So here I am, and sitting with a patient, and let's say I'm about to do a crown prep on this lady here. And for some reason, I'm dressed up in business casual instead of a clinic coat, but whatever. I'm like, so, all right, lady, are you ready to get started on this crown prep? And she's like, yeah. And then Carly pops in and she's like, can you come back into room 5? Mr. Jones's crown still feels a little high. And I'm like, yeah, I guess. Yeah, I'll be there in a minute. And then Kathy is like, we're ready in op six. And I'm like, op six? I didn't know there was a patient in op six. What are we even doing in op six? And then all of a sudden a hygienist comes in and she goes, I need a hygiene check. And then another hygienist comes in. She's like, I didn't need a hygiene check too. And what I realize is, even though I've been a dentist for over 20 years, is that I don't know if I have the capacity to handle that much. Like my brain is only so big. And it's like a lot of my brain is devoted to this crown prep that I'm about to do. Some of it's going to be devoted to whatever is happening in op six. And then what happens to me is I go into that room where that hygienist is waiting for me, and I see the bite wing that's up on the screen, and my brain, my eyeballs, everything goes like that. That's what happens. Okay. I start off, this is what's on the screen. And then my eyeballs and my brain and my mind and my consciousness and my attention goes like this. Because all I'm focusing on is like, what? This patient's coming in for a regular cleaning and checkup. What happened with 14? I'm thinking, dude, I probably need to do endo. How am I going to break it to this guy? This guy comes in, no pain. I'm about to tell him he needs a freaking molar endo. And then I'm looking, I'm like, Dad, does he need crown lengthening? Should I do the crown lengthening? Should I refer him out for the crown lengthening? God, how do I tell this guy all this? That's what my brain does. And it's possible that at that moment, while my brain is scrutinizing over all this stuff, and my brain also is focused on all these other things that I have going on in the office, I might just, I don't know, ignore all these other things. The fact that the patient has incipient decay in the enamel on one, two, three, four, five, six different surfaces, the fact that the patient has a ton of interproximal calculus, is it possible that I might miss that? Yeah, because I'm human. I don't want to miss it, but I miss stuff like that. I think a lot of you, if you looked at these bite wings, you would see that mesial calculus on tooth number 19, but I don't know if I would have seen that interproximal proximal calculus in between 18 and 19. And that's why it's 2019. I mean, it's 2026. I kind of feel like all of us should at least be open-minded to the fact that AI-driven radiographic interpretation occurs. It exists. Now, I happen to use Pearl. Pearl is not a sponsor of today's lecture. I have no financial relationship with Pearl. I don't get a kickback from Pearl. There's nothing like that. But I happen to use them. I happen to like them, and I know that there's competitors like Overjet that exist. But you all are now dental professionals that are practicing in 2026. And if you're not using AI, if you're not embracing tech, I just want you to ask yourself why you're not doing it. And if your answers are not satisfactory in providing you with a I want to be the best possible dental professional I can be, then maybe you should start looking into something like this. Okay. So anyway, we look at those bite wings. And the question is, what are we going to do with these bite wings? So let's make this an experiment here. Okay. I want you all to follow with me all of these bite wings. And I want you to count how many cavities there are. Okay. Hopefully I'm not going too fast. I apologize if I am. All right. Now, my count was 9, but like we're not going to argue. You might have been like 9. I only saw 7. And somebody else would be like, I saw 12. Well, who cares? I counted 9. Okay. I didn't have the gift of radiographic interpretation through AI, so I counted 9. Now, I know for sure that if I had back in 2002, when I was a dental student at the University of Michigan, if I showed these bite wings to my instructor, I could have told my instructor that I am recommending nine fillings. And my instructor would have said, go ahead. Now, you would think that would have changed over the last 20 years, but it hasn't because my wife, she's a preceptor at Case Western Reserve University in Cleveland. And I know for sure that at Case Western, where even though things are cutting edge, it's 20 years later, 24 years later, there are still instructors that would say, yeah, yeah, I see nine cavities too. Go for it. Do nine DOs, MOs, and MODs. Go for it. Go for it. Just pick up the syringe, pick up the drill, and just freaking go wild. Hey, 17-year-old, 17-year-old kid who's otherwise totally healthy. Hey, 17-year-old who's never had a cavity before, but once you got your license, you started going to Starbucks, started drinking those mocha lattes. Now you have more sugar in your diet. Now you have nine cavities. I'm about to drill in nine different surfaces in your mouth. I'm going to give you nine MOs, DOs, and MODs. And I don't think any of you would be surprised to later on in that 17-year-old's life see x-rays that look like this. I don't think this is an uncommon occurrence. More than likely, some of you are going to go to work tomorrow. You're going to see a new patient or a recall patient. You're going to be looking at their bite wings, and you will see something along the lines of this. Now, let's look closely here. You have some, you have a filling on tooth number 21 that looks like there's maybe some recurrent decay at the mesial, or at least an imperfect seal. You have some weird overhang, crap, dust, gross stuff in between 19 and 20. You have a definite overhang on the mesial of 12. You have, I don't know, whatever that is on tooth number 11. Maybe it's a unfilled DL filling. You know what? All of you are looking at this, and probably there's some of you who are like, God, who was that dentist? That dentist sucks. And I'm tempted to do that too when I see bite wings that look like this, and they're not bite wings that I did. Thankfully, this isn't one of my patients, is a patient that came to see us. But I thought to myself, man, I bet you that dentist wasn't trying to do harm. That dentist wasn't trying to do something bad. That dentist did the best they possibly could. But the fact is, class twos are hard. Look at all of these bite wings. All of these bite wings started with the same freaking thing. A patient was young. A dentist looked at their bite wings and said, you have decay in between your teeth. I'm going to drill on those teeth and I'm going to give you an interproximal restoration like an MO, a DO, or an MOD. And then what happened? Over the course of decades, what happened? Look at the x-ray that is on the left side in the center, the x-ray that is on the right side at the bottom. You have teeth that started off with MOs, DOs, MODs, eventually turned into endos, eventually turned into crowns, eventually turned into failed endos. And that is the timeline of dentistry. You take a patient when they're young and they're healthy and they have a couple incipient decays and you say, hey, I'm going to do a DO. And then when they're in their 40s, you say, oh, God, you have more decay than I thought. We're going to have to do a deeper filling or a crown or endo. And then when they're in their 60s, something fails. You pull the tooth, you place an implant. And then if the patient makes it to 80, some of that gum tissue around that implant has started to recede. Threads are showing, and that patient starts experiencing periimplantitis. This is the timeline of dentistry. This is not unique. This is not unique to my office or your office. This is all offices. This is why implants exist. And I think that this is a problem because when we start that process, when we start the timeline and we do a DO filling on a tooth on an otherwise healthy 19-year-old, we start the timeline. We start the timeline of a unpleasant dental story for the rest of that patient's life. I believe that drilling on enamel is barbaric. I mean, think about it. The rest of our bodies is totally squishy, soft. We're just this big, squishy, goopy human. And for some weird reason, we have things that are as hard as diamonds emerging from our gums. And those diamonds should be cherished. But because we're dental professionals, because we have been given a license to put a metal or diamond drill bit at 200,000 RPMs, we can obliterate that enamel. We can just turn it to dust. And I think that's barbaric. I think that's weird that we can do that. enamel being so valuable, being so hard that we can just obliterate it, especially with preps, the size of the preps we have to do in order to do a class 2 composite. What about this? Do you look at the distal of tooth number 29? Do you know why I took this bite wing? It wasn't because I thought I had done something wrong. I took this bite wing because I thought I did everything right. I thought I did such a killer, awesome, amazing job at that class 2 composite that I did on tooth number 29 DO that I said, "Hey, assistant, take a bite wing. I want to I want to just look at my work and brag to myself about how awesome a dentist I was." And then I looked and I was like, "Oh crap, it's not good dentistry, it's bad dentistry." I ended up giving that patient gingivitis, not because I'm a bad dentist, not because I'm a lazy dentist or a rush dentist. It's because class twos are hard. Look at these. Look at all of these. I would say that maybe the only picture that I see up here that has a perfect seal is on the upper right, maybe the lower right. Those are the only pictures that have a perfect seal. All the rest of them, it's an imperfect seal. There is a possibility that you're going to give the patient an overhang with the seal that's been created with this sectional matrix band. And the question is, I know a lot of you are like, well, I don't do that. No, sure you do. You just don't happen to take photos at the time that you're placing your sectional matrix bands. Once you start taking photos, if you become an educator or something like that, or if you just take photos just for the heck of it, you're going to be surprised at how many times you do a class 2 that actually looks pretty good in the mirror, but doesn't actually look perfect once you take a photo. And if it is imperfect, you are going to create an imperfect margin and therefore the possibility of leakage or an overhang. Both of those are bad. It's not because you're bad, it's because class 2s are hard. The other thing is the ADA doesn't want us drilling on incipient lesions. It's pretty clear now. The research is out. Lesions that are just in the enamel, like these two little black dots that you see on the lingual of this upper molar, we shouldn't be drilling on those. We should be doing whatever we can to stop the progression of decay and potentially remineralize that decay. See, let me show you how it works. This is enamel, but this is boring. So I want to show you what I see as enamel. This is enamel. So you probably have some laying on the floor in your basement. These are Nerf bullets. Okay? So when I hold Nerf bullets together and I super glue all those Nerf bullets together, that is what enamel is. It is this big collection of super glued together rods. But when we eat anything that has sugar content, that strep mutans can turn into acid, or if we eat something that's already acidic, what we do is we dissolve the super glue holding onto the enamel. What we do then basically is the enamel rods are still there, but the super glue that's holding all those rods together, that super glue becomes dissolved, and that process is called demineralization. Okay? A lot of us right now are undergoing the process of demineralization because we had just eaten our dinners. But what's really nice is that naturally, because of our saliva, our super good saliva is going to come in there. It's going to buffer that acid. And there are elements of our saliva that are going to remineralize those enamel rods in a matter of a few hours. So before we go to bed, a lot of our enamel rods are going to be super glued back together. That's a process called remineralization. And it's actually kind of great because that's why most of us aren't going to go to work tomorrow with a bunch of cavities. Even if we ate a brownie tonight or something like that, we're probably not going to get cavities because we have a natural defense against cavities. That is our naturally occurring superglue that's found in our saliva. Great. The problem is that some people lose that battle. Some people eat too much sugar, and that dietary sugar is insurmountable by our natural saliva defense. Or some people, they eat normal, but their saliva is just not as good as yours and mine, and that puts them at high caries risk. Okay? So what do we do for people like that? Well, if a person has high caries risk, one of the first things you can do is just say, hey, you know what? In the last year or the last 5 years, I've recommended three cavities. I feel like you have a bunch of little lesions in your mouth, little white areas that look like they're going to become cavities. You know what I think we should do? I think we should paint fluoride on your teeth on a regular basis. Why don't you come in every 3 months? We don't even have to do a cleaning. We're just going to paint some fluoride on your teeth. That's one thing that you can do. So, one of the most effective ways to prevent eventual cavitation, where you actually lose enamel rods, is to expose a patient to more fluoride, whether it's topical fluoride in the office or some type of fluoride at home adjunct, which I'll talk about in a second. Okay. Most of you probably have never heard of this. And this is Cavity Fighter. It's made by the CAO group. This is a product that when you have a patient, how many of you have had a patient like this? You have a husband and wife. Husband and wife have really similar lifestyles, similar diets, similar home care. They drink about the same amount of water. Husband never has a cavity, wife has cavities. And she's like, what the hell? What? I have cavities? Why doesn't he have cavities? And sometimes I'm like, I don't know. Like, you guys pretty much have the same habits. I don't know. I mean, sucks to be you. But one way that you can tell for sure why that wife has a cavity is by actually using something called cavity fighter strips. And these are basically little strips that the patient just puts in their mouth for a couple seconds. And when they take it out of their mouth, you'll see colors at the end of those strips. And those colors will tell you whether the patient is at a higher risk of getting cavities or a lower risk of getting cavities. This is cheap. It's cheap. You don't have to charge your patient anything for it. But what you now have is a documentable way of telling a patient whether they're at high risk or low risk for cavities. Now you can be like, dude, I know why you get cavities and why your husband doesn't. It's because you have unlucky saliva. And the next thing the patient's going to say is like, well, what do I do? What should I do? How can I fix this? And now that's where there's a variety of things that we can do. Once you determine that a patient has high caries risk, you can put fluoride on more often. I'm a fan of the Prophysil product by Kettenbach. They didn't sponsor today's lecture. No, I don't have any financial relationship with them. However, their fluoride is it's less waxy, it's less gross. So I'm a fan of their fluoride. This is their QR code if it's something that you'd like to try. It's just the least gross of the fluorides, but there are so many topical fluorides that are out there. Ultradent has one, Voco has a topical fluoride. There's probably proprietary fluorides that come from Henry Schein and from Benko and Patterson. Whatever you choose, just suggest to that high risk patient that they use more of it. Okay. Another thing that I want to make sure that you all at least have in your radar is increasing that patient's home care defenses now that now that we have already determined that they have a high caries risk. Number one is a lot of people, the reason that they have high caries risk is because they are not producing enough saliva. It's not actually about their buffering capacity of their saliva. It is because of medication or old age or whatever has made it so that they don't produce as much saliva. One very, very nice take-home product that they can take home is this all-day dry mouth spray. This is made by Elevate Oral Care. Elevate also makes the highest concentration fluoride toothpaste that you can give to a patient. Okay, all day 5,000. Again, I'm not sponsored by Elevate Oral Care, but I really like their products. So things that you can suggest to a patient that they can go home with. Dry mouth spray, a toothpaste that has a ton of fluoride. For those of you who prefer Remin Pro over MI Paste or vice versa, my decision making is basically based on taste. You can ask the patient to, after they brush their teeth, use Remin Pro as almost like a lotion that they can put on their teeth to make their teeth a little bit less susceptible to get decay. And then Cavity Fighter, the same company that makes the high risk, low risk strips, they actually have these little chews that they recommend patients chew after they have ice cream, after they have brownies, after they have cookies, because it's an immediate buffer to the resulting acid that would be created by the strep mutans after the patient eats some sugar. Okay. This is a product that probably most of you have never heard of. It is just a fabulous thing. It's inexpensive that you tell patients, like, listen, I want you to quit eating sugar altogether, but if you're going to have it, pop one of these. It's like eating Tums for somebody who has a propensity for having a gastric reflux. This is the same thing. This person has a propensity for getting cavities. Have them chew a tooth Tums, basically. And what that's going to do, it's going to reduce the pH in their mouth. Okay. But some patients, the cavities are there. You've already done everything you can to suggest to them how they can reduce the potential of getting new cavities. But what do you do for those patients who already have cavities? And I want to talk about two strategies, two products first. The first one is SDF, silver diamide fluoride, that when I first learned about SDF, it was taught to me like this. Tell me if this sounds familiar. Um, you could put this on people's teeth, but it will turn their teeth black. Have you heard that before? Yeah, that's how it was taught to all of us. It's this product that was relegated only to people who are in certain income brackets where they cannot afford a cavity, a filling. So you're saying, oh, okay, you know what? You can't afford a filling, so I'm going to paint some stuff that's going to turn your teeth black onto your teeth. And I think that the way that that was presented to us was incredibly irresponsible. First of all, SDF doesn't turn teeth black, it turns decay black. And the reason that I choose Riva Star Aqua instead of traditional SDF is because Riva Star Aqua has two particular aspects that make it, in my opinion, a superior product. Number one is that the step two component of Riva Star Aqua, it actually leaches out some of the silver that is in the step one. And what that means is whatever blackening effect it has on the decay, it's going to reduce the blackening effect. What I have found is that when I use Rivastar Aqua, the cavity turns a little bit more of a brown rather than a black. So it's a little bit easier on the eyes. But number two, and I think this is the biggest one, when we use Rivastar Aqua, which is two steps, you don't have to have that patient come back in 2 weeks for a second application. And with all other SDF products, best practices say if you're going to put SDF on a patient, paint some SDF on and then have them back again in 2 weeks to paint it on again. That is unnecessary with Rivastar Aqua. It is, you have the patient, if you notice here, this patient has two occlusal cavities. I was able to get a stick with my Explorer for both of those. There's no way in H word that I'm going to drill on either of those because I wouldn't want my teeth to be drilled on if I had two little pinprick sticks. So this is the step one for Rivastar Aqua. If you notice, my microbrush is turning kind of black itself. Step one will turn the cavity black. It's traditional SDF. Now, step two, if you notice, the step two created kind of like a little white precipitate. What you want to do is you want to keep on scrubbing until the precipitate disappears. If you keep on scrubbing until the precipitate disappears, what you're going to essentially do is you're going to minimize the chances of that cavity turning and staying black. Now, if you notice here, the tooth isn't black. The tooth stayed the same color that it already was. The cavity is what changed colors. If you don't already do SDF because you're afraid of black, you just have to try it. What you're going to find is a lot of patients are going to be like, yeah, I already kind of have a black dot on my tooth as it is, or I can't really see in between the interproximal of my teeth. I would be happy to use SDF. The problem with SDF is that SDF is a caries arresting agent. It stops the progression of decay, but it is not actually that effective at remineralizing. It is an absolutely wonderful product when you have decay that has penetrated into the dentin, um, where a remineralization product is not going to be enough. This is a wonderful way to stop the decay and prevent that patient from needing a filling done until maybe 5, 10, 15 years down the road. I've been doing this now for several years. I have patients who, in another lifetime of mine, I would have done an MO on them. But it's been 5 years and I'm still haven't done the MO. I'll probably do it at some point. But what I'm doing is I'm trying to push that timeline as far back as possible. Maybe if I do that MO when the patient is 40, then they're going to need a crown when they're 60. And then maybe they'll need an endo when they're 80. And then maybe by the time they need an implant, they're going to be dead. And what I've done is I've won the dental timeline. I have held off on the MO. I've held up on starting the snowball of bad dental outcomes by using a tool that's going to stop the progression of decay. But what do I do here? What about this one right here? What am I going to do? Now, this is, in my opinion, and this is confirmed by the radiographic interpretation by my AI software, that both of these cavities are fully within the enamel. What I want to do, because they're fully within the enamel, I want to do everything I can to remineralize that enamel. I don't want to just stop the decay. I want to remineralize the enamel. Now, back in 2005, I could have gone up to my residency director and I could have said, "Hey, I think I should do an MO on 18 and a crown on 19." Can you imagine the amount of perfectly good enamel that we would be obliterating by doing an MO on 18 and a crown on 19? In my opinion, I think that's totally unethical. I wouldn't want that done on myself. If I had these two puny, tiny, incipient lesions, I wouldn't want my enamel to be absolutely obliterated. So what I want to do is everything I can to remineralize that currently demineralized enamel. And that's where I want to introduce you to a product called Curodont by Vivardis. Curodont is basically, so here I have this patient, okay? Remember, a little bit of incipient decay between 18 and 19. What I did for this patient is we found the cavity was there, we saw the bite wings. And what I need to do in order to apply that Curodont is etch the surfaces, etch that interproximal surface. So I'm just trying my best to see if I can sploosh some etch into that interproximal. But one way that I know for sure that I can get etch all over that interproximal is to use a some unwaxed floss. Curodont will not work if you use wax floss because it would leave a waxy residue. So you use unwaxed floss to make sure that that etch gets distributed. The funny thing is a lot of times when we do this procedure, it is in the hygiene room. And the problem with the hygiene room is that they never have a high volume suction, which is so annoying. So now I'm trying to remove etch with a slow speed, but a low volume. Now, this is how Curodont originally was provided to us. It came in this like goofy, flaccid brush that was so annoying because by the time I pushed the brush onto the tooth, the brush was so flaccid. It like I couldn't even get it to like smash up against the thing. So what I needed to do was use an extra instrument to smash it into place. And what I've found as an educator who talks about Curodont is a lot of people are like, dude, I tried it, but I hate that stupid brush. It was so annoying. It was all flaccid. And the one thing I'm going to tell you is they've changed their formulation, so we don't have that brush anymore. Now, Curodont is done the way that we express the Curodont onto an interproximal lesion is actually with a cube. And I'll show you how that is in a second. This is a different tooth, a different situation where a patient has interproximal lesions between 18 and 19 and 19 and 20. So what I would do in this situation is I would pull out two cubes, one cube for 18 and 19 and one cube for 19 and 20. Okay. The first cube, what I'm going to do is open that cube and I'm going to use the Curodont liquid and drop some of that Curodont liquid onto the cube. Okay. Basically, this liquid is what's going to make that cube able to express its magic, its remineralization magic onto the tooth. Okay. One thing I want to make sure everybody is clear on, the cube The cube itself is what's magic. It's not the liquid. The liquid is the less important adjunct. It's the cube that is magic. The cube is what has the actual proprietary peptide that makes Curodont so valuable. So now the cube is getting it's sitting there soaking in the liquid. I'm gonna go ahead and go through and floss the area between 18 and 19, between 19 and 20. I'm gonna use etch in between those teeth. Same way that I did the first time. And again, I'm going to use floss to try to really see if I can smash that etch all over the interproximal area. What I want to do is etch the actual affected enamel that is currently being affected by that interproximal lesion. Okay? I'm in my room here. That's why I get to have the isolite and the high volume suction, which is awesome. But a lot of times that I apply Curanon, I'm applying it in the hygiene room. So now, because it's a cube, I can smash it, smash it. That makes it so much nicer. Now, here's the rule when you smash that cube, all the magic is gone. I cannot now take the cube and put it between 19 and 18 and 19. I can't do it. That cube is used up. All of its magic is gone. So that is the one thing that you have to make sure you're aware of when you're pricing this out is that you charge a patient per smash. I don't charge patients per lesion because I don't want to charge them for 19 mesial and 20 distal. That's not fair. I'm doing the same smash. I'm using one cube and one smash for those kissing class twos. But if the next tooth over has interproximal incipient decay, I'm going to use a new cube and I'm going to charge a patient for another application of Curodon. Okay? So just uh, what's the word? A review, SDF stops decay. It does not replace lost enamel rods. Fluoride varnish will demineralize enamel, but very superficially, only about 25 microns. Curodont is the one that's going to replace lost enamel rods. But if it gets into the dentin, it's very questionable whether it is still effective. So those are some things for you to just keep in mind. Okay. This is the
Dr.
QR.
Gupta, we're at about 8:40.
Dude, it's perfect. All right, great. I'll be done in 5, 6 minutes and then I can take questions. Sound good, Lisa?
Perfect.
Okay, so just so you know, both SDI and Vivardis, they did sponsor today's lecture. I am getting an honorarium benefit from those companies for my highlighting of their products at this lecture. I just want to make sure you all know, though, that I do several lectures throughout the year in which they don't sponsor me, but I still highlight the exact same content because I just really believe in their products. I would talk about them every time that I lecture because I use them. And I am a very, very big fan of non-invasive dentistry. Okay. Problem is, what do all of these products have in common? The topical fluoride that I was talking about, the toothpaste that you can send home with a patient, the SDF, the Curodont, they all have something in common. And that something in common has been made into a villain in today's society by our Secretary of Health and Human Services. And while I disagree with people who follow the Maha movement, I believe that those people still deserve respect. Um, I think that a person with high caries risk should have their teeth exposed to fluoride. But I know for sure that there are patients in my population, along with your population, who say, no, I don't want fluoride. I don't want fluoride. I don't want my kids to have fluoride. I don't want any of that stuff. Here's what I want to tell you. For those patients, don't be a jerk to them. Listen, if you're a jerk to somebody, what that means is you're a jerk. Okay? Don't be a jerk to people who you disagree with. You try to be as respectful as possible to everybody in your life and say, listen, I'm going to tell you right now that the best product, in my opinion, for you to use is a fluoride product. However, there are products that exist that might still help. They may not be as effective as fluoride, but they might still help. Okay. The product that is on the right is a really wonderful toothpaste. I tried it. I use it. I love it. I love this toothpaste. Now, I don't have high caries risk, but Coco Lab is a fully hydroxyapatite toothpaste. There's no fluoride in it. Uh, and it's like delicious. I mean, it's just a great toothpaste that is made by Coco Lab. And then let me tell you about Riemann Gel. Riemann Gel is a gel that is made actually by PerioProtect. For those of you who use PerioProtect, Perio Gel in your office, Riemann Gel is made for patients who have high caries risk, whether or not they're against fluoride. It's a really nice gel that they can put into trays and on a regular basis bathe their teeth in something that's going to make their teeth a little bit stronger and less susceptible to decay. So I have my patient over here. She just had a lot of kind of white spots, like just that white demineralization at the along the gum line on so many of her teeth. Really high caries risk. I mean, over the years, I've done crowns on her, I've done root canals, I've done fillings, just a really high caries risk. And the one thing she really values about me putting Riemann gel, and these are just regular bleaching trays that we made her, cheap little highly accessible bleaching trays that we made her, is that now when she's watching a TV show, she's just bathing her teeth in something good. That's it. Hydroxyapatite with a variety of other ions. This is a really effective way. And the thing is about Riemann gel that I like is that it's a gel. It's so easy to clean up. I've given patients trays and said, oh, put MI paste in this. It's just so hard for patients because it's really hard for them to clean up. They have to use their Sonicare inside of their trays. This is a gel, it washes off really nicely. And PerioProtect also has a Riemann gel that has fluoride for your patients who are perfectly fine with fluoride. So this is another option that you can try. It's made by PerioProtect. A lot of you probably have already heard of PerioProtect for your patients who have gum disease. There's a really nice product for your patients who have a high caries risk. Okay. The other problem I have with non-invasive intervention is I don't really know if it's working or not. 6 months later, sometimes I'm just like, all right, well, I kind of still see the incipient. Doesn't hasn't gotten worse, but it's kind of still there. I think it worked. I want something a little bit more documentable. And so, one way that you can have documentable evidence of whether or not your stuff worked is by using pH 6 called CaviSense. So, here's one of my assistants, Jadriana. She is eating a little like fruit snack. Okay. So, basically, she's just eating a little piece of candy that has a lot of sugar. Now, if she has a cavity, an active cariogenic lesion, then what's going to happen is within 10 minutes of her eating that candy, the bacteria that is living inside of that lesion is going to start to produce acid. So all we do is simply stick a CaviSense pH stick in between her teeth, let it sit there for 10, 15 seconds, and then pull it out. That's it. And that's going to determine if it turns yellow, that means it created that the bacteria in between her teeth created acid. That means that she has an active lesion. If it stays purple, that means that it's no longer an active lesion. You can say, "Oh wow, cool. My non-invasive intervention with Curidon or with SDF or with some of the take-home stuff, it worked." So anyway, CaviSense, again, not a sponsor, but it's a company whose product I think is pretty innovative. So if you're interested in something like that, you can learn more about it by doing that QR code. Okay. So here's my advice. You have a patient with high caries risk. They have several incipient lesions. You do not want to drill on them. So in the office, make them some trays, provide them with a prescription strength toothpaste, like Prevident or All Day 5000. Apply SDF or Curidon to those incipient lesions and apply fluoride more often. Have them come in once every 2 months, every 3 months. At home, have them brush with that toothpaste. Have them watch a TV show or take a shower with their Riemann gel trays in. And if they're going to eat something sugary, have them chew on some cavity fighter chews. It's a win-win-win. Everybody wins. Everybody wins. Patient doesn't got to get numb, doesn't have to get drilled on. They don't have to spend $200 for a filling. For me, the dentist, I don't have to break my back doing a really difficult procedure in 60 minutes. 18 MO, 19 DO, that's hard for me to do in 60 minutes. And for the hygienist, all of a sudden their production skyrockets because along with just doing a prophy, they are recommending SDF, Curodont, tray therapy, fluoride placement. They're not breaking their back, yet their production numbers are going to increase. Here are some codes that I think you'll find helpful. And I want to end by letting you all know that I created a little half-page pamphlet for patients that basically says exactly what I talked about today. Uh-oh, you were just told that you have some cavities. We're so sorry. Nobody likes hearing news like that. Let's follow a few simple steps so you don't have to get your teeth drilled on, get your teeth numb, all of that kind of stuff. And here is a summary of all the things that they can do at home with their home care, with their diet, what they can do at the dentist, what products that they might be able to pick up at the store, etc. And this little pamphlet that I made, it's available to you on my website. This I made this on what's it? Canva. I made it on Canva. My Canva link is on my website. If you want to steal this exact, dude, use the exact same thing and just delete the my practice's logo up there and obviously delete the picture of me and my wife and my practice website and put your own stuff on there. It's all good. I'm happy that people are using that and maybe drilling less. So that's it. This is my contact information. For those of you who are who like to do Instagram, Facebook, social media stuff, that is how you can follow me, learn about what upcoming lectures I have. I do a lot of videos of actually doing procedures in the office that people find helpful. If you want to download my notes, that's on bebetterseminars.com. If you want to email me, that's my email address. I generally do respond to emails. I just am not very timely. Sometimes it takes me a week or two to respond to people, but I try to respond to everybody. With that said, let me stop my share. All right. Hormoz says, how soon could you confirm your treatment with an X-ray if cavity is crossed enamel into the dentin? Do you take the risk by treating with fluoride? So Hormoz, I actually, when I have very, very, very like it just crossed into the dentin. Like it is a very, very shallow decay that has crossed into the dentin. I am still going to use SDF. I'm not going to drill yet. And then 6 months later, I'll take another bite wing. I'll use CaviSense, etc. So I'm much more on the conservative side. I'm much more on the non-invasive side. I don't know if what I'm saying is the correct thing, but it is correct for me based on my practice philosophy. So hopefully that helps. Um, I think it's Young or Wanzik. How much do you charge for Curodont? Okay, so each smash is $75 is how much I charge. I practice in Cleveland, Ohio. That's fine with me. I think that um, my overhead as a practice owner allows me to charge $75 for Curodont and still feel perfectly profitable. If you are practicing in Dallas, San Francisco, um, New York, New Jersey, you might be charging $125 in order to still be profitable. That's up to you. But I would say that probably the national average is $100 per smash. How do I present? Let's see. Also, how do you sell PerioProtect Reman Gel? Okay, can I tell you how I tell the patient, Young? I say something like this. Listen, um, Young, every time I see you, I'm always giving you bad news. Like, it's got to suck for you. It's frustrating for me, but it's got to be worse for you. And I'm saying, oh, you have a cavity here, you have a cavity here, and I'm kind of sick of saying it, and I'm sure you're sick of hearing it. What I want to do is I want to throw everything that I can at you to minimize your chances of ever getting a cavity again. Okay? And some of it is how you're going to take care of your teeth at home. It's some of it is what type of food you're going to eat. Some of it is how much water you're going to drink, and some of it is some of the things that I can offer here at the office. Okay, and at that point, I talk about Curodont SDF. I talk about him going home with a special type of toothpaste. I talk about making trays, and I say, listen, Young, everything that I just talked about is going to cost about this much. And if you're like, I'm not ready to spend that kind of money just yet, I totally understand. Let's see what would work for your budget, but will also be as effective as possible. Sadly, the fact is, the most effective thing that we can do is to do all of these things. And so I want to be as respectful as possible of your budget. And that's how I say it to patients. Does everybody do trays? No. But I've actually reached out to Perio Protect and we do a lot of trays. We are a very, very high volume tray office. And I think it's just because probably because of the way that we talk to patients in that way. So anonymous attendee, can you post the codes again? Yeah, yeah, give me a second. Lisa, can you just confirm? Do you see the codes?
Yes, I do.
Hmm. Cool. Okay, anonymous attendee, take a screenshot. Ready? Three, two, one. Cool. All right. Let me undo this now and stop my share. All right. Oh, what were the codes again? Cool. What about baking soda chewing gum recommended by Dr. John Featherstone, world expert in fluoride clinical use? I think that's great. I actually need to just learn more about it. Baking soda chewing gum sounds like a wonderful option. Yes, because that is going to take the place of what Cavity Fighter would be doing. It's going to be reducing that pH. Love the idea. Martin, I just haven't used it myself. I haven't employed it myself, but that would be such a cool thing. That'd be so cool to after the patient's done with their we talk to them and everything like that, and we give them a little goodie bag, and in the goodie bag it has some of that gum. That is such a good idea. Martin, I appreciate it. Check back with me in a year, and I'll probably have that as part of my lecture content, and then I can give you credit for it. Okay? George, doing a class 2 filling, say MO on 19, but DO has precavity. If used Curodont on 20, will it affect the bonding of tooth number 19? Okay, so I've actually reached out to Curodont about this, and I have not gotten a good enough answer from either hardcore Curodont users or even Curodont, the company. I don't know if it's going to affect the bonding. So I would much rather fill 19, do the entire restorative procedure on 19, and then use Curodont interpro. It sounds like, dude, it would be so much better to just smash the Curodont when I've already prepped 19 because I have so much access to that decay. But because I don't know about whether or not it will affect the bonding, I would rather finish 19 and then smash the Curodont into that already closed contact interproximally. That's how I would do it until I find out for sure that that Curanon isn't going to affect my bond. Okay. You don't have to read this, but thank you for a fantastic lecture. I'm just going to read it anyway, Anonymous. This is amazing and inspiring. Just wanted to say that RFK Jr. is against systemic fluoride, not topical fluoride, and the fact that it is given to everyone without informed consent. But seriously, your lecture is the best one I have heard in a while. Oh my gosh. Well, thank you so much. And actually, I appreciate that. All I want to make sure that I do is not be a dick to people who are against fluoride. I just want to be as respectful as possible. But that's actually nice to know that that the thing that he is against is systemic fluoride in our drinking water. Okay, and Sabatino, why not insert an interproximal wedge for better access when acid etching and doing the subsequent non-invasive treatment? And I totally agree with you. Only problem is I'm lazy. That's the only thing. I mean, like, yeah, that sounds great. But all I know is that because I lecture on this topic and therefore I talk to a lot of other Curodont users, I think we're all lazy. And what I've found is that the proprietary peptide that is in Curodont is very effective at making its way interproximal with or without a wedge. So I've actually talked to the founders of Curodont, and they're like, you do not have to use a wedge. However, and if you want to use a wedge, I bet you there's absolutely nothing wrong with that, and you probably will have a slightly more increased efficacy than the way I would do it as a lazy person. Lisa, I think that's all the questions. You want me
Okay.
to?
Yes, that is.
All right, cool, 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 cool. Okay, I'm just gonna go and look real quick on chat. Lots of people just saying hello and where they're from. Oh, Holly said, I love your Instagram post, and Dana said, go blue. Dana, I'm not normally even a college basketball fan, but that was so awesome. And then let's see. Can you apply fluoride varnish immediately after SDF? Yes, you can. Can you tell me the name of the metal toothpick for checking acid between teeth? Oh, it's not a metal toothpick. It's a pH stick, and it is called CaviSense, Mark. Mark Molinsky. Cavi, C-A-V-I, Sense, S-E-N-S-E. And I think that's it.